We've got two great experts with us today. Got Dr. Craig Charles, is the medical director for Affinity, and Anita Case, who is the center's executive director and known for a long time, does a fantastic job. Thank both of you for joining us. The CDC recently updated their guidance on symptoms suggestive of COVID-19. Can you update us on the symptoms of COVID to watch for, and when should our listeners call our healthcare provider if you're just not feeling well? Doctor?
Thank you, Congressman. So I think we all recall when COVID first came around, we were told the standard symptoms to expect: the cough, the shortness of breath, the fever, and every week new symptoms seem to be attached to this syndrome, which has made it all that much more difficult to handle, to screen people for potential testing and such. And so the next things that came out were a little unusual. I remember seeing a patient who said, "I lost my sense of taste and smell this morning." And that was our first positive test, was a patient who responded to different questions with kind of an unusual answer. And sure enough, a few days later, the CDC reported that this was being reported by patients around the country. And so each week there's been newer symptom complexes added to help keep us on our toes so that we can screen people appropriately. The next thing we heard about was some GI symptoms, which you don't necessarily associate with a respiratory virus. We started hearing about nausea, vomiting, and diarrhea, and sure enough, we've had some patients with those symptoms test positive. And then today, I've read that there's also something called Kovat Toes, where the skin on the tops of the toes becomes slightly discolored, and this is a new symptom that is being reported and associated with COVID. So every week we learn about some new symptoms to hear about. If the patient doesn't say they are having fever, we need to be aware that they might be having chills, which is often a surrogate of a fever. So those are sort of our symptom complex that we keep updating on our screening questions that we ask of patients who come to the clinic. And so it's a quickly evolving problem that
Changing every day, isn't it?
Yeah, it sure is.
Anita Case, I know you've been on the front lines and see it all. You want to add to what Dr. Charles said?
Well, he is the expert. I would just add that we're also screening for sore throat. I mean, I think that was one of the newer ones, and I think he covered it beyond that. So we've definitely had folks who test positive who did not have a fever. So I think just being aware of all the different symptoms is important.
Let me ask either one of you or both of you, if symptoms are mild and really don't appear to be worsening, is it likely that the doctors will provide testing or recommend testing, I guess?
I think it depends, and it depends on whether that doctor has the ability to test that patient or to send them where they can be tested. Because if a provider is contacted by a patient with some symptoms and they're not really sure how to test, maybe their clinic, their office doesn't have the ability to test, they may be reluctant to recommend testing for that patient. For us, it's easier because we are doing aggressive testing. And anybody who calls in with any of those single symptom complex items that we just outlined, any one symptom, we're recommending they be tested.
Let me ask this. If our listeners don't have a healthcare provider, they do not have a doctor, what do they do?
Well, I will say that across your district, there are community health centers. And so I think it's a great time to engage and get a primary care provider if you don't have one. And all of the health centers across our state are doing telehealth. So it's a great time to connect. You can get started with health care through telehealth safely from your home. You can get assessed for COVID, through telehealth. So I think it's an opportunity to reach out and find out who are your health centers in your community health centers. Also, I think private practices are accepting new patients. Everyone needs a healthcare home, and this is just one opportunity to get connected.
But our testing capacity is pretty substantial, and we're testing anyone. all comers. If they're registered patients with our clinic, great. We'll certainly test you. But if you're just a community member who doesn't already have a provider, or your provider's just not offering testing, we'll screen you for the symptoms, and we will line you up to come through our parking lot to go into the testing queue, and we will collect specimens and submit them for testing and let you know what your results are.
What's the timeline now? If I come in and get a test, how long do you wait?
Well, if you're positive, we're probably going to know about that in about 24 hours, maybe even less. Negatives are taking longer. They're obviously not priority reporting. The lab is not calling me in the middle of the night to tell me that your test was negative. They are calling me to tell me that your test was positive. So sometimes we have to actually reach out to LabCorp, our lab source, and get those negative results so that we can pass them on to the patients and let them take them to their employer and be cleared to go back to work. So in essence, within 48 hours, I should know if you're a positive. It may take anywhere from 3 to 4 days to finally get our hands on the negative test results.
That's an improvement, big time.
It is.
It is.
Mm-hmm.
The CARES Act requires health insurance plans to cover COVID-19 testing, and it also provides reimbursement for providers who test uninsured patients. So if I'm uninsured and need a test but haven't yet met my deductible, I still won't have any out-of-pocket expenses. Is that right?
That's right.
Yes, I think the one thing to be mindful of is, I know that the COVID testing is covered, but if you get other services during that same visit, you just want to be mindful of those costs. Like if you got a strep test as a part of that visit, then you might have that cost. But a lot of uninsured folks can get tested through community health centers like us, and it's no cost to them. And then insured folks who get testing with us or with the other health centers, that's free of charge as well.
All right, now for our listeners, what paperwork or documentation should they bring with them? Insurance card. If they're uninsured, what type of ID? What should they bring?
So we do ask people to bring their insurance card, but at Affinity Health Center, we're also collecting that information on the phone because we want to limit that exposure. So we're just going to be very quick with the test and any documentation that we're exchanging. We do look at IDs. If someone doesn't have an ID, we don't want that to be a barrier to testing. So, we're just looking, is this the person that we screened on the phone, and make sure that the lab is notified of the right person. So even a debit card, a credit card, anything with someone's name, we can accept that as well. So yes, insurance card if you have one, ID if you have one, or some form of proof of who you are. That's really it.
Great. Now walk me through the test itself. And I've heard a lot of people, you've seen it on TV, they take the swab and there's a reaction that is it painful? Well, walk me through what that process is.
All right. Well, first, the patient calls and inquires about testing, and they're asked a list of questions to see if we really want to test, because we're still following the CDC recommendation to test symptomatic people and not asymptomatic people. A lot of people want just screening. Have I had it? Did I have it last month when I was sick? We don't do that yet, not at Affinity. So the patient calls, they get screened. If they have any of those symptoms we outlined, even just one, we put them in line to be tested. They come to our parking lot, they come to Affinity, and we have a parking attendant meet them and hand them a consent form, and we ask them to read and sign a consent form and show us their ID to identify it's the right patient we scheduled. Then they simply pull through the parking lot up to a tent where we have our testing crew made up of a nurse and a couple assistants. And they roll down their window, they're identified, and they are. We have a test kit with a requisition, a lab requisition. Now, here's where the swab comes in. Our folks on the test crew will collect the specimen. Now, there are two basic types of swabs that can be submitted for COVID testing. There's what's called a nasopharyngeal, and the naso means nose, and there's oropharyngeal, and the oro means mouth. Either one is accepted by LabCorp for testing, and you don't have to have both. You can have one or the other, or you can use both if you choose, but we only collect one specimen. In our parking lot drive-through testing, we stick with the oropharyngeal swab. The swab is probably about 8 inches long or so. It looks like a very long Q-tip, and it's just like a strep test, if anyone's ever had a strep test. They have the patient open their mouth. They do a quick swab along the tonsils. They really need to get good contact with the tonsils, so it can be a little uncomfortable. And some people who have a very sensitive gag reflex may also have a little discomfort from that. But they get a good swab of the tonsils, and that's it.
How about the nasal?
Now, the nasal swab, which we do more often in the clinic. Now, if someone gets into the clinic and we realize, oh, this is a COVID patient, I might do a nasopharyngeal swab. And that's, if you've ever been to the carnival and saw that guy who pretended to drive a nail into his nose, well, the reason that works is because the passageway right along the base of the hard palate is a clear pathway to the back of the throat. So that is a very long swab. It is very thin, but it's very long, and it just goes right along the floor of the palate in the nasal passageways all the way to the back of the throat. Yes, it can be very uncomfortable, and people usually react appropriately. But that's if you do it right, because if you do it wrong, you won't get a good specimen, and you may get a false negative test. So if you have someone take that swab and they just kind of rub up and around the front of the nose, that little space up in the front of the nose, that's not the way to do it. You have to get way back there. And it's a harder test to collect, and that's why we stick with the oropharyngeal swab in the drive-through, and we only do the nasopharyngeal for some folks who come into the clinic itself.
Okay, say I've gotten the test, you have not gotten the results back. What should you do if you've been affected, and is it you got a test for a reason? Should they self-quarantine? Should they? What advice would y'all give?
Yes, you're right. And I want to take a second to explain the two terms that are often used interchangeably and explain the difference. There's quarantine and there's isolation. We've all heard both of those words. Quarantine is what we typically do for well people. Like, I got exposed to somebody with COVID and I'm worried about getting sick and I want to stay away from folks. I'm going to quarantine myself at home in case I become symptomatic. Isolate is what we do for folks who are sick. Isolate yourself at home, still the same kind of thing, but it's the terminology is different. If you're sick, we want you to isolate until you get better so that you don't pass it on to other people. So someone is coming through our drive-thru, they have symptoms because we only test symptomatic people. They're symptomatic for something, so it might be COVID. So yes, we want them to isolate at home until we know whether or not it was COVID positive or COVID negative.
And who will actually call?
We have a nurse also. Well, for positives, we have a nurse who will make the call and instruct them of the results, and also give them some instructions and advice on what to do. Positives should also expect to be called by our state DHEC office because they will be checking on the epidemiology aspect of it, contacts, and things like that. Negatives are going to be called either by our nurse or some other support staff at the clinic who are able to just call and give a negative report and tell them that it was negative, they're okay.
What is the ratio of? I mean, if you test negative, is that a pretty high? Is that is your success fail rate?
Yeah, that's a good question, and it's hard to answer with a whole lot of certainty. I will say this: if your test is positive, you can take that one to the bank. The what's called the specificity of this test is really, really high. That means if it's a positive, it's very likely to be a true positive and not a false positive. The negatives are a different story, and they're a little more difficult to answer because there's so many factors that apply to this. Collecting the specimen itself. If the person collecting the specimen didn't do a very good job, you may get a false negative. Time of day can even play a role because of when you get back to the back of the throat where the virus we expect it to be, it might not be very plentiful at that point of day or in that spot of the throat, so you may get a poor specimen. So what's called sensitivity is more difficult to answer. How likely are the negatives to be true negatives? There are some reports that we might even have 30% false negatives. So it's a little worrisome, but the best thing to do is try to get a good specimen, try to do it right, try to collect it correctly.
And I'll remind the listeners, it starts with, if you suspect you may have it, it starts with going to to get tested, and that's the beginning point. So what's on the horizon for testing? I mean, you hear about changes with the heat, with the summer. Is that what's your take on that?
Well, the thing about the seasons and the warm weather that I'm hopeful for is that it helps people stay away from each other more. This distancing, the reason we have cold and flu season in the cold weather months of the year is because that's when people are gathered together, schools are in session, kids are all together, people gather indoors to get out of the cold. And that's why we trade colds and flu in the cold weather months. And in the warm weather months in the United States, we get away from each other more, and it breaks the cycle. So I'm hopeful that will play a role in our flattening the curve as well. But in addition to that, we also are going to want to know who has had it, who had it and got over it, who had it and didn't even know it. And that's where some of these antibody testing techniques are going to come into play, because that's the way we tell who actually had it and who didn't. Those are on the horizon. There are some available right now. We are not doing that kind of testing at Affinity, but it's going to be a very important component going forward of figuring out what was the incidence, how many people really did have it, and then calculating how many people died, who had it, because the death rate may be lower once we realize the number of people who had it and didn't even know it. So that's going to be something that will be pushed to do later, probably in the warm weather months as well. Not necessarily seasonal, but just as the availability of that testing comes out.
Well, y'all have done a great job. How is your staff holding up, Anita?
I think much like Michael from DSS, I mean, our staff are, they're dealing with the same concerns, fears, anxiety that everyone else is. They all come to work every day, and they know that they need to be there because we're healthcare providers, but they still go home to their children or the people they're caring for. They are concerned and fearful, but I think they are strong. They're doing the best they can. We've tried to get creative in how we offer support and provide opportunities for folks to just lean on each other a little more, and recognizing you may need to take a walk a few times a day, or just get away and to take a breather. We've done some meditation, mindfulness things. So I think that much like the rest of the country, that they're scared and they're afraid, but they're committed. And I think that's healthcare workers all over, and social workers and all of those in the helping field who are continuing to go to work every day and serve people and put themselves at risk, but also knowing that this is what they've been called to do, and what they need to do.
Well, your family, you really are.
Yes.
Okay, Anita Case, Dr. Craig Charles with Affinity Healthcare. Great center. I've been through there, Anita, when you call me. Great people there. It's a calling. So thank you for what you're doing. We appreciate you taking the time to come.